log into
Did
that.
you send us?
Is that the last one in there?
Yeah,
This is
this
the
morning.
last one.
Oh, okay.
Hold on. Send it to you this morning.
Yeah, I'll have to move my
Because I
cursor,
put
I'll be
everything
trying.
on one,
Good, you're good.
because this is gonna be quick.
Is this on the test?
One question. But it's easy. Did you guys do your, questions?
Yeah.
Did you discuss it with one another?
I can't say I
Yeah?
discussed it.
No?
They got 2 days.
Yeah, I have some more review questions for you. All the questions you have are, as many questions as you can get are good questions, are good. Of course, you know, this Wednesday we're gonna have the Moodle, it's gonna be on Moodle. We'll bring some exams into the class just in case anybody has a problem. I also resent you the internet thing. There was a president sent, if you're having trouble with internet, click on so-and-so or fill out an application for, I think that's for internet. I don't know if that's it for internet at home or internet here. I'm not sure, but I know some of you have a problem with internet here. If you do, you know, hopefully we can get that resolved. Any questions about anything we've done modality-wise? Low rate, high rate, low width, conventional pens, acupuncture pens, muscle re-education, blah, 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 alternate mode scanning. Hello, Melissa.
Hi, Doctor.
Hi, Mel.
Scanning, modulation, adaptability, no, everybody's good? All right, I understand some people were able to be here on Friday, and some people take advantage of this week, okay? Because the practical is on Monday, so take advantage of this week, and if you need additional time, if it's tomorrow, or if it's Wednesday, or if it's Thursday, or, you know, take advantage of it. Let us know if you need open labs, and we'll make sure that something's available, okay? Yes, no,
Yes.
maybe so?
Thank you.
Of course.
Absolutely don't know.
All right. How you doing, Chris, all right? Yeah, kinda quiet there. Unlike this Chris. And Andrew. Monica, you all right?
Yeah.
Isaiah? Yeah, you good?
I'm doing good.
Ah.
Joe, how are you?
I want to just make sure that you guys are good. Jade, you all right for Wednesday?
Yeah, I feel pretty good.
So you know you have to know buoyancy and all that kind of stuff. I sent you a bingo. Did you do the bingo? Yes? You got it, right?
We got it.
Yeah, I've been feeling pretty good.
All right. So let's talk about traction. We could do traction via mechanical traction. You could do traction with your hands.
Oh, I'm sorry,
You
I
could
do
do-
have one question.
Yes. You have a question already?
You sent the unit compression.
Compression.
You can go over the PowerPoint on compression.
Yes, we're going to finish that after traction. I just figured traction's easier to do.
Oh,
So I put them all together actually, and I added some more pictures. So, manual versus machine, so you could do a manual traction. Anytime I do cervical traction for a patient, I usually do it with my hands. I don't use a machine, however, there are machines that do mechanical traction for both the cervical spine as well as the lumbar spine. Okay, there is a reason that people do traction. So we could do traction for joint distraction and joint distraction. What's the definition of traction? To pull apart. So longitudinal traction is to pull two facets apart or two surfaces apart, or two, not even a facet for lower extremity, but you could do traction on extremities. Upper extremity, lower extremity, if somebody's getting osteoarthritis and you want to do longitudinal traction for the limb, you could do traction that way. You could do traction for an upper extremity. And we have a lengthening of the tight muscles, so the time on and time off, when you do time on and time off, it's like a contract, relax. So it stimulates the GTO to inhibit the motor, alpha motor firing, so we can get a relaxation on the muscular system. We want to decrease radicular symptoms. And what are radicular symptoms? Symptoms emanating from the root itself and traveling down either the upper extremity or the lower extremity. So the more distal symptoms, the worse the problem. So if the problem is more centralized, it's a better outcome than if something's more distal. So if we think about a herniation, if we have no pain in the back whatsoever and we have a pain in the big toe and it's coming from the herniation, that's a bigger problem. Okay, rather than just a large amount of pain in the lumbar spine itself. So the traction that we'll be doing associated with HNP is associated with facet hypertrophy. Okay, we could do traction for spondylolysis, spondylolisthesis. Well, actually not spondylolysis, but spondylolisthesis. We could do traction for degenerative joint disease or disc disease, to increase range of motion, to decrease muscle spasms. We could do traction for that, to decrease pain. So what do? We separate two articular surfaces. So when you separate two articular surfaces, you then release compression or relieve the compression of a nerve root, okay, within the intervertebral foramen itself, by distracting or by increasing the movement there, you can take pressure off the nerve. So you could also reduce a disc by traction. Soft tissue stretching, muscle relaxation, because we get a stimulation of mechanoreceptors through muscle stretching, joint through the oscillation. So it's similar to what we do when we do joint mobilization, because we do a little distraction followed by an oscillation, and that oscillation will stimulate the mechanoreceptors. So joint mobilization, patient immobilization. So we can immobilize the patient with a low traction force, so 10 to 20 pounds maybe, and to immobilize the patient for a particular amount of time. Not done too much anymore, because we know that if somebody's got a back problem and we keep them in bed for a week, they usually get worse. Used to be done a long time ago. Now we know we need to get this person moving right away. All right, so here are some of the parameters. All right, I just want to see if my notes are the same. Yeah. Position the patient's head in 25 degrees of flexion. Why don't we position it in extension? Vertebral artery, plus we want to increase movement, right? We want to increase the movement between the facets. So in order to do that, we have to put the head in flexion. So head in flexion, 25 degrees. However, we don't do that if somebody's got an HNP. All right, that's why I don't do cervical traction, a machine. For HNPs, I do manual traction. However, if you wanted to do it on a machine, you would do it with the head in neutral. Okay? So your head weighs approximately 15 to 20 pounds. Some people's heads weigh more, some people's heads weigh less. So you need at least 25 to 30 pounds to produce that spinal elongation. Greater amounts may actually cause a problem. So the upper cervical spine takes less weight to reduce than the lower cervical spine. And as a rule, when we do traction for the upper cervical spine, we don't want to go any greater than 7% of a person's body weight. Okay, I don't know who figured it out, but it's in every book you look at, 70% of a person's body weight for distraction of the cervical spine. Okay, you don't want to have a large amount of force of the cervical spine, because you don't want to cause a problem, and you don't want to increase muscle guarding. So by increasing the muscle guarding, it'll relate to increasing muscle spasm. So whether the traction's on all the time or the traction's on and on-off depends on what the problem is. Yes?
I'm sorry, you said 7% or 7%?
7% of the patient's body weight. If we wanted to do facet distraction for the thoracic and lumbar spine, mostly lumbar spine is what we're talking about, because we're distracting the lumbar spine, not so much the thoracic, but the lumbar spine. If we wanted to have facet distraction, we need 50% of the person's body weight. If we just want elongation of muscle, we use 25% of the patient's body weight, okay? So we have to know how much a person weighs, and you're going to go about approximately 50% of a patient's body weight to get facet distraction. Okay, for muscle, to elongate muscles, it's only 25%. Okay, that's something you should remember. So static versus intermittent, the shorter the time on, the more comfortable. So generally we have the traction on for 10 on, 10 off. Depends on what the manufacturer says too, on the different kinds of machines. But for an HNP, it's 1 to 3, so 20 on, 60 off, if you're going to use mechanical traction. Okay? And you could have it on for about 20 minutes if you have somebody that you want to keep in bed, and you have a traction device on them, and that would be with a pelvic band and a harness, and some weights on the end of the bed. You can keep them in for 24 hours. All right, so treatment time 20 minutes, 24 hours. HNP about 8 minutes, because the disc will imbibe the fluid if you have it on any longer than that, and it would actually increase that intradiscal pressure. So you're not going to have it on very long. There's auto traction, and that auto traction is self-traction. So self-traction, you could do different techniques which would provide traction. Think about if you wanted traction or longitudinal traction through the upper extremity, you could just hang on a bar. Okay? You could also hang on the bar in non-weight bearing to have traction through the lumbar spine. Okay? There's different types. There's home units, which are over-the-door traction devices. So these over-the-door traction devices only allow you to have, and you fill these bags with water, and they only allow you to have about 20 pounds. So it may not be very effective. If you want to use cervical traction, you're going to make sure that you have a mouthpiece, especially if it's a traction that's attached to the wall, because as the harness is around your mandible and it pulls in an upward direction, it's going to compress the TM. So you want to make sure there's some kind of a mouthpiece or something separating the teeth. Okay? Let's see. There's a spreader bar and there's a rope. I'll show you a picture of it. And there's an occipital halter. All right. So you need approximately 50% of the body weight in pounds to distract the lumbar spine, which we said before, and only 25% for muscle. So if you want to position the patient on a traction unit, you're going to position them supine with their hips and knees flexed. So the knees are going to be flexed. If the hips are flexed about 45 to 60 degrees, you're going to distract the lower lumbar spine. The higher you flex the hip and knees, the more that you can target a higher level. Okay? So they're 45 to 60 degrees for L5S1, 60 to 75 degrees for L45, and a little bit higher, 75 to 90 degrees to distract L34. What's the most common sites for an HNP for lumbar spine?
L405, L5S1.
L405, L5S1. What are the signs and symptoms associated with an L45 disc? Andrew, if you thought somebody had an L4-5 problem, where would you see myotomal and dermatomal and reflex problems?
So the reflex would be with plantar flexion. Reflex.
What reflex? L4, what reflex?
Well, L4 would be dorsiflexion.
Reflex? L4, reflex, dorsiflexion? Is that what you're saying? We have a reflex, we have a myotome, we have a dermatome.
Myotome would be.
Myotome would be dorsiflexion. Where would,
Reflex would be plantar flexion. Or like
reflex would be plantar flexion?
Yeah, Achilles, not.
L4? Chris?
Knee extension, or the patella.
Patellar reflex. Patellar reflex. And what about dermatome? Oh my goodness. This was last semester, not 10 years ago. Chris?
L4?
L4.
Uh,
Yeah, it didn't change since last time I asked.
we are talking medial, shin, and gastroc.
Yeah. Medial shin, medial
Gastroc.
calf. Yeah.
Okay.
You guys should know that.
Oh, yeah.
All right, you should know that. Just because it was last semester doesn't mean you forget. Okay. So, can you use with unilateral traction, prone, HMP? Okay. For prone, if you wanted to use mechanical traction, you could put the person on their belly. I'm sorry, for a lumbar, I should say, I said for prone. For an HNP, you could put a person prone and do traction. You could also do unilateral traction, and depending on if you had a split table or you want to prevent the effects of friction on a table, so you could release the table so you do that and you prevent the friction. You could, because otherwise you'll slide. So you could release the table and allow the person and put the traction on that way. You could also put the traction on unilaterally. So if there are different cuff weights for the ankle that you could put on that would do a unilateral traction. You don't see that done much. I did it years ago. Problem though, I'll tell you who I did it with. I did it with a gentleman who lived in Toms River, and he used to come all the way up to Newark to be treated. So he felt great when he was here, and we completely relieved the pain. I mean, the pain subsided. But then by the time he got home, he had pain. Why? Because he sat in a car for 2 hours or an hour and a half, yeah. And he sat in a car with a posterior tilt, even though I told him to modify his sitting posture by having a lumbar pillow. And, so you have to take into account a lot of things that this patient does after you get him off traction, because if they are non-compliant, it doesn't get better. And nowadays, some of you said that you wanted to be McKenzie certified. I think that's a great thing, because McKenzie's not the end-all and be-all of physical therapy, but it's certainly something that you could put in your toolbox. There's a lot of extension and lateral shifts and different things that you could do with disc problems, and they work great. However, when you're in a fix or you're in a bind, you could use a mechanical traction. Yes.
My only issue with McKenzie is they treat everyone the same regardless of different symptoms they present.
But that's why I said it's something that you could put in your toolbox. It doesn't apply to everybody, and it shouldn't be used for everybody, and you shouldn't have the same technique for everyone, because everybody's different. But if you have a classic derangement, because there's different types of derangements, and the greater the distance away from the disc, the greater the derangement, and there's derangements that cause for extension with lateral shifts, there's derangements that call for extension, and there's derangements that cause for flexion with lateral shifts, which is flexion. So if you put everybody in one box, then you miss it. Yeah. But I understand what you're saying, because a McKenzieite will just treat everybody with McKenzie, and that's not. That's why I'm saying keep an open mind and learn as much as you can about a lot of things. But I do believe in it. It works. And there's studies that show, evidence-based studies that show that it does. Okay, so static, you can use it static traction, 29 to 44 pounds for 5 to 10 minutes. Intermittent is joint distraction, 15-15, so it's same time on, time off. The decreased muscle spasm is 25% of the body weight, 5 on, 5 off. Disc reduction, 25% of the body weight, 60 on, 20 off. 60 on, 20 off? Somebody look that up in your Cameron book. I'm not sure, that doesn't look right to me. Because I don't use mechanical traction for disc, but just look that up, or I'll look it up. But, you guys should look that up. Just red flag that last thing, disc reduction. Soft tissue reduction, okay, but disc reduction, I'm not so,
So these are seconds.
these are seconds.
And the machine, you just set the strength of it for the,
You set the time on, time off. A lot of people don't even set it, because it's already set in the machine. However, you have to know, if you're gonna be working with a disc, it's different than just working with, it's an equal time off for, time on, time off for everything except for disc. Okay, I'll look that up. I'll look that up.
It's correct.
What, I'm sorry?
It's correct.
It's correct? Okay, so it's correct, all right. Thank you. Like I said, it's been so long that I've done this for a person. 60 on, 20 off. All right. Okay. Spondylosis, psychoarthritic disorder. Spondylosis, osteophytes, fracture of the cervical spine. So here we look at a side view of the anatomy, and you could see that you have this spondylosis, or this in the cervical spine. It's most common between 5, 6, 6, 7, right? Okay, so we have the disc start to degenerate, or the vertebra start to degenerate, discs start to lose water. You see osteophytic formation, and as you see these osteophytes, then they're pressing on nerve roots. Okay? So this is different. This would be what would be normal. This would be somebody who has arthritis. Right? Okay. Spondylolysis is actually a fracture. Remember I said before, spondylosis, spondylolysis, spondylolisthesis. Spondylolysis is a fracture of the pars interarticularis. Okay, so that's right here. And when they do a lateral view when they look at it, because they're looking here, you'll see a collar on a Scotty dog. So they usually refer to it as a Scotty dog fracture. Okay, that's the pars of interarticularis. That's that spondylolysis. I had a patient have this. I only saw 2 patients that had this. Both patients were athletes. One patient was a professional volleyball player. Okay, why? Because of the extension. Yeah. I mean, really aggressive, really a lot of force generated. Yeah. So he has spondylolysis. Okay? That we're not going to do traction for. Spondylolisthesis, we will. What does this look like to you? What does it look like to you?
posterior translation or herniation.
Spondylolisthesis is in the anterior slippage of one vertebra on the other, usually at 4, 5, L5S1. So anterior slippage of, and they're in grades, grade 1, 2, 3, 4. So grade 1 would be like it slipped 25% anteriorly. Grade 2 would be 50, grade 3, 75. Then you have a lot of instability. So what kind of exercises do we need to do with somebody who has spondylolisthesis? So it's anterior slippage of the vertebra. What do we need to do? We need to bring it posterior, so what kind of exercises do we need to do?
Flexion.
Flexion?
Or something going where the anteriorly.
So what do we need to do with the pelvis? What do we need to do with the trunk?
TPT, like a posterior tilt.
Posterior tilt, abdominal exercises, yes. Yes. Especially somebody who's like this, right? Somebody who has a rear gut, or somebody who's pregnant, or somebody who's just has a lot of adipose tissue. We want to make sure that we keep that neutral pelvis, or we go into a posterior pelvic tilt. We want to make the abdominals strong.
Where's it most common? L4 or 5? What you said?
L5, L4, 5, L5S1. Same thing as a disc.
Okay.
Okay, so anterior slippage. More so L4, 5. Okay, so more so on L4, 5. So indications, when do we want to do traction? If somebody's got an HMP, traction manual versus mechanical, it's your choice. A nerve root impingement, joint hypomobility, want to increase movement. Subacute joint inflammation, not acute. And paraspinal muscle spasms for that gating mechanism. Okay? Contraindications, because we always have to know contraindications, right? Hypermobility. So under hypermobility, we have RA, we have Marfan syndrome, and we have Down syndrome. Does anybody know what these are? Does anybody know what, you have a C1 and a C2, right? What are the C1 and C2 bones called?
Atlas and the
Atlas
axis.
and the axis, right? And what do we have that sticks up from the axis into the atlas? A dens or an odontoid process, and that has to stay in place, right? So how is it held in place? How are any bones held in place? Yeah, there's a transverse atlantal ligament that holds it there, right? Otherwise, it's going to keep going up. So that this ligament stabilizes the cervical spine. So if you have any kind of a ligament laxity, which you do in somebody who has Down syndrome, they're associated, and RA, you get a lot of bony degeneration, and you can get ligaments that are affected that are not doing their job anymore and stabilizing the vertebra, and the axis can go right up into the brain. Okay, so it can cause you to die. So, and joint instability, cervical instability is not a good thing. So, and you could also have paralysis, et cetera, et cetera. So if we have somebody who has Down syndrome, and I make this comment because I had a patient like this. I had a patient who had Down syndrome when she came into the clinic because she had thoracic pain. So when I looked at her thorax, and we were doing stim, et cetera, for her pain wasn't going away. So I did a specific test, which therapists do, known as a Sharp-Purser's test, and I looked at the integrity of this transverse atlantal ligament. And when I moved her head, because I stabilized her head and move it this way, I heard a clunk. So when I heard a clunk, I knew that this ligament was not stabilizing the cervical spine. So the doctor wanted me to do traction on her and do mobility exercises, and I had to call him and let him know. And she was in surgery the next day. So I'm telling you that this is really, really important that you understand that Down syndrome is contraindicated to work on somebody's cervical spine with traction. Same thing with RA, because with RA you get ligament laxity and you get degeneration of the cervical spine. Okay, so those are the two things. As well as Marfan syndrome. Anybody know what Marfan syndrome is? It's connective tissue disorder and it's systemic. It's associated with laxity.
Of limbs and extremities.
Yes, very, very long, spider-like fingers, very long extremities, very long. You know who had it?
Michael Phelps.
Abraham Lincoln.
That makes sense.
Abraham Lincoln had Marfan syndrome. And it's systemic. Okay, a lot of ligament laxity. You need to do stabilization exercises for these people, not mobilization. Okay, so these are absolute contraindications. Peripheralization of symptoms. So you're working with this patient and now the symptoms got worse. Right, they came in, they only had pain in the back. Now the pain is completely gone from the back, even though it was excruciating. It's completely gone. It's just a little in the fingers. Is this a good thing? No. No. Okay? Spinal cord pressure. So if they have pressure on the spinal cord, osteoporosis. If they have osteoporosis of the cervical spine, we need to do stabilization because we have weakening of the bones. Uncontrolled hypertension, especially in somebody who you want, and this is coming back, I'm sure you've seen it in some of your clinics, inverted traction, where they put your feet in these traction, they put you in boots, they strap you in, and then they turn it upside down. This is traction for the lumbar spine, the cervical spine. However, if you have uncontrolled blood pressure, it's not something that you want to do. Okay, you don't want to put a CVA in inverted traction. Spinal mets, because they have metastasis, so you have weakening of the bones, and spinal infections. Okay, there's also we talk about RA, there's also RA in children known as Still's disease. That's juvenile arthritis, so you're not going to do it in somebody who's got juvenile rheumatoid arthritis. Okay? Ehlers-Danlos that's a different thing, but I'm thinking about what else, because that's systemic hypermobility too, but sometimes manual traction's okay for that, so forget that. All right. Precautions, sequestered disc, what's a sequestered disc? Anybody know what sequestered is?
Is that when the Johnsons?
They sequestered the O.J. jury, remember? They had a jury panel and they sequestered them. They removed them they kept them, sequestered is displaced. So displaced disc, because it might not do anything for that. A medial disc, something that's more medial to the nerve root, when you do traction on it, may cause more of a compression on the disc itself. Somebody who doesn't tolerate it, somebody with TMD, a pain that's removed completely by traction, because now what have you done? You've created a nerve block. So you've actually made it worse. So, tumor, because the integrity of the spine is compromised, maybe by metastasis, as well as infection. And if somebody's got TMD dysfunction, remember I said you have an occipital halter or the mandibular strap. If somebody's got dentures, what do? You keep them in. Do not remove them, okay? Because they're acting actually to decompress that joint. Okie-dokie. Lumbar, cervical, mechanical, static, self-traction, disadvantages, advantages. We talked about there's different treatment times, and advantages is that, especially with an overdoor traction, you can generate some forces and it's cheap. You could also have a little cervical traction unit that's an auto traction that all you do is, it's a pneumatic kind of device. We have it in the lab, so we'll show it to you, and you could actually cause some destruction. Disadvantage of these big machines is that they're very expensive, it's time consuming, and also when you do joint distraction, it's difficult to isolate to specific segments. So if you put somebody in a cervical traction and your head is about 25 degrees, you're generally isolating something that's a little bit lower, which is okay, but you don't know specifically, am I doing C5 on 6, C6 on 7? Okay, so it's a little bit, rather than if you have your hands on somebody, then you could be more specific. All right, that's why manipulations are not the greatest thing to do, because when you manipulate, you don't know what you're manipulating. Okay, because you're taking the person to end range and you're just doing a quick thrust, and there may be other segments that may be manipulated that have ligament laxity or that may have stretched of ligaments. Very common, happens very common. Okay, so red flags. Red flags for any traction, you've done traction, now the patient has pain in both arms and legs, right? What if somebody comes in and they say, and when in your evaluation or your assessment, they say to you, oh, I have to go to the bathroom, oh, I really have to go, oh, geez, it's just, I don't know what's wrong, it's just, the pee is just coming out. And you say to them, well, does it happen often? Well, it's been happening a lot. So that's a red flag, right? So what is that indicating?
That's
2, 3, 4,
involvement.
Joe, what did you say?
S1, 2, 3, 4.
S2.
S2, 3, 4. S2, 3, 4. So maybe you have an L5, S1 disc, and now it's affecting S2, 3, 4. What does that mean? It means it's large. It means it's large, and it's compressing all the nerves below that level. It's contraindicated. Okay? What if somebody has night sweats? Night sweats are a red flag, right? It indicates some kind of infection. Active infection is going on. Cancer, any kind of an infectious disorder, metastasis, cancer, spinal infection, tumors.
Could it also just be a warm room?
Could be what?
Oh, like a hot room?
Hot room?
Yeah, I sweat through the night regardless.
Yeah, every time I sweat now, I think I have cancer.
But sweating profusely is different than just a hot room. All right, it's a hot room, you throw the covers off, you get cool, right?
Yeah.
That's what happened to me last night too. You throw the covers off because damn, these covers, there's just too much, my husband and these covers, like, I'm just gonna, but then I got cool and then I pulled the covers back on. No,
Okay.
these people will just be sweating. Their pillowcase will be wet, their bed will be wet, their
Okay.
clothes will be wet. Yeah. And if somebody has an unexplained swelling, unexplained edema, fractures, you certainly don't want to, you don't want to mobilize a fracture. Yes.
On S2, myotone was knee flexion. Knee flexion
Knee flexion?
for S2,
Knee flexion for S2.
yes.
What do you mean knee flexion for
For
S2?
myotone, I thought that's what we're talking about here.
Oh, okay.
Muscle control, because we said S2, S3, S4 for bowel and bladder. I thought S2 was knee flexion, and S3 through 5 was bowel.
Well, she also told us before, like S2, 3, 4, pee on the floor. That was
Yeah,
like
S2,
in
3,
the
4 comes from perianally and goes down.
So there's like overlapping?
Oh, sure.
Okay.
Sure. S2, 3, 4. Yeah. Okay. So these would be contraindications, red flags. So here's a traction. You see that you have a harness, a pelvic harness, and you have a thoracic harness. And these harnesses are attached at the top and the bottom. You see your knees and hips flex, and you see that they're on this bench. Okay? And she's being given a on-off switch that if it becomes uncomfortable or there's a problem with it, she can turn the machine off itself. Okay, you always do that because you don't want to just leave a person in the room and then walk out and come back a half hour later and find them all twisted up or some problem with it. Yeah.
So, you mentioned on red flags that fracture is a red flag. Was this Scotty dog fracture?
Yeah, you don't want to mobilize, you don't want to mobilize the scapular fracture. Spondylolisthesis is not a fracture. Spondylolysis is. Spondylolysis. Spondylosis is arthritis. Spondylolysis is a fracture. Spondylolisthesis is that anterior slippage of the foot. Okay. Okay. This is self-traction. So again, she's got her feet up and this is a mnemonic. She's just pressing on it. It's causing distraction. This is cervical traction over the door with the water. Okay, you put this harness on you, but you could see that the mandibular, it's sometimes occipital as well as mandibular, can cause compression of the joint. So somebody's got a TMD because they have a whiplash, or maybe they have a whiplash and they don't even know they have TMD. You put them in this and then they start having joint pain. Okay, so we understand that that may happen. And these are the units we have in the lab, so you'll try these today. Okay. All right, compression.
Are we gonna do some manual traction?
Excuse me?
Are we gonna do like manual traction in mine too? Or are we just gonna like hook each other up too?
Are we gonna do manual traction?
Yeah.
No,
Oh, bummer.
no.
Bummer. Okay.
You can. No. No, this is not a class, that's above the scope of your practice right now. You could do it when you get into the second year. But you guys haven't touched enough people to understand what it is you're touching. You know, I'm telling you that when you do I had to do a practical in my advanced masters for orthopedics where I had to do a 3-degree movement of the cervical spine. And they told me to hold my hand here and tell them when I did it. I mean, that's how,
That is stuff that's pretty specific.
so it's not, it's beyond this. Yes?
I've noticed like some of the auto traction stuff, so like the cuffs for the neck and stuff. Can you exercise someone while they're actively in traction? Would it be beneficial to work the muscles in a range of motion where they're not used to? Or would you ever exercise while you're in traction?
No,
No?
no. Traction is just for distraction. So we don't want to, if you want to actively exercise somebody, then you're going to introduce muscle contractions. You don't want to do that. Okay? All right, so when we talk about compression, we said that there's a balance between hydrostatic pressure and osmotic pressure, and the osmotic pressure is determined by the concentration of proteins in and out of the blood vessels. We said that last time. So, compression is what we do, we want to get rid of the edema. So venous insufficiency will cause edema. Lymphatic dysfunction will cause edema. And again, I said we have this balance of these fluids in and out of the blood vessels. So compression is really to move the fluid or to modify scar tissue, and that's why we use compression. So, indications are for lymphedema, and lymphedema is associated with a lot of things, including mastectomies. All right, mastectomies are probably the biggest reason why you'll be seeing this. A new residual limb. So we could use compression for somebody who's got an AKA or a BKA, or transfemoral or transtibial amputation. Somebody who's at risk for a DVT. So we can use compression with that. And in fact, to use compression pumps and devices in-house in the hospital for edema. The kind of edema that you want to make sure you do compression for. You don't use compression for every kind of edema. Can you think about when you might not want to use compression? Yes?
So you use compression if the person has DVT?
DVT? Okay, so to prevent a DVT, you would use it, but if somebody had a DVT, you wouldn't use it. Yes. Any other times you think?
Arterial insufficiency. Someone who has arterial insufficiency.
Somebody has what?
Arterial.
Arterial problems? Okay, so somebody's got an arterial dysfunction or arterial insufficiency? Correct. Any other time? How about bilateral edema associated with CHF? Do we want to use compression? No, because you just overload the system, right? Okay, so we'll talk about that in a second. Stasis ulcers. So we use it with venous ulcers, right? Can we use it with hypertrophic scarring?
Indicated.
Yes? No?
Yes.
Yes.
All right, so you're in this sleeve. You guys tried the sleeve last week, right? Some of you, did all of you try it? No? So you try it today. All right. So you put this sleeve on, you usually put a tuba grip or something on it to absorb the sweat, right? If you're gonna put it on your skin alone. And you should just put it on your skin alone, have a tuba grip. The tuba grip, the device itself is not heated, however, it's non-porous, so you get hot. Right? So when you get hot, you sweat. So we want to make sure that we wear some kind of a tuba grip or something to absorb this, because we're not going to put this sleeve on somebody else directly after we use it. So this heat that's generated will increase these pressure-sensitive enzymes that are in your skin itself, and that's known as, or in the body itself, I should say. And collagenase will be released. Collagenase is something that breaks down collagen. So it's very good for scar tissue. It modifies scar tissue. So that's why we have compression garments, such as the Job's compression device, where Linda was talking to you guys about it, that you wear these compression garments. As soon as you take off this compression device, you would place on a compression garment, because it'll control the scar tissue. And remember, you had a lecture on burn. And I don't know, Roy Vaughn probably told you about that woman that had the mask, the face mask, and then they asked her to take it off. So these compression garments are worn 24/7. The only time you take them off is to take a shower, and then you place them back on. So it's thought to hold down, the collagenase breaks down the collagen, which will help control the scar tissue. So types of units. We see here, and I think Linda talked to you about that. Circumferential inflates as a unit, as a whole. Constant remains inflated. Intermittent goes on and off. Sequential starts from distal proximally. The chambers will inflate individually from distal proximally. And so can you use it with air, which these pneumonic devices that we have in lab are used with air. You could also use it with water, like the Game Ready and all these things that are compression devices, and they're associated with ice. So they not only control the edema through compression, but also through ice. Okay, so through cold. So we have two type of modalities that are working at the same time. And Linda also mentioned, to some of you, maybe not all of you, but we also talked about it, and we talked about edema last semester, or massage, I should say, and we said that when somebody's got a large amount of edema or lymphedema in the lower extremity, what do you have to do first? Start proximally or distally? Start as proximal as you can. So if we're doing the lower extremity, and Linda is a specialist in lymphedema, so she'll work with the chest and then go down. But when we're working with these patients in clinic, if we want to do a massage to the lower extremity, we'll massage the upper thigh first and then the foot to the thigh. So we'll open up lymphatic channels proximally and then go distal proximal. Okay? So edema reduction, to decrease inhibition. Let's see. So the fluid is pushed into these interstitial spaces and it's picked up by the lymphatics and it goes through the system. Return to the system. Prevention of DVT increases venous flow and prevents blood clot formation. We said that already. Mechanical pressure, blah, 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 decrease edema. Acute setting, okay. So this is just a picture. I think that's why I put it there. So we force the fluids proximally, and why do we do this mechanically? Because normally your own muscles do this mechanically, right? Veins have one-way valves, and they rely on muscle contraction to push the fluid back into the interstitial spaces and to be returned to the superior vena cava and then go through the circulatory system. Okay. What do I want to say about this? So it's just the lymphatics pick it up, put it into the venous system, and that also lymph has a great amount of protein in it. So it's associated with, you can have bacterial infections if you have too much lymphedema. Okay? That's all. So this will help remove waste. This is the same thing. Oh, we were talking about this last week a little bit. Prevents orthogenic joint inhibition. And orthogenic joint inhibition is just if you have swelling in any area itself, you're going to have an abnormal afferent information bringing that's brought to the spinal cord, which results in abnormal efferent response. So what does that mean? It's going to decrease your muscle strength. Okay, so orthogenic inhibition. And they've done this with normal healthy patients. They've taken a knee and they've injected some fluid, just water. And then they've looked at the effects of the water on the joint. And they found that the joint doesn't respond appropriately and you have a decrease in muscle strength. Okay, so it's evidence-based. Pain decreases, decreased pressure on nerve endings associated with the edema. It's all about the edema. It's the same thing. All right, this is important. Compression bandaging. Oh, I know what I wanted to say. Remember we talked about protein and hypoproteinemia. So if you have if a patient has hypoproteinemia, what does that mean? The other day we mentioned it very quickly. We talked about albumin, right? And we said that the albumin, if you didn't have enough albumin to hold in the blood to hold the fluid in, it'll leak out and produce edema. So if somebody doesn't have enough protein in their diet, you'll have edema. So make sure that you look at albumin levels. If you look at the blood work and you look to see if they don't have enough protein. Okay, but probably you'll see something more in the albumin, a blood level, and it'll be less than 3. Yeah.
I'm looking at blood work. What's a normal level for albumin? In
3.
Blood? 3. So anything less than or equal to 3 is.
Okay. So if Una boot. Una boots work very well. Una boots are wraps, or compression wraps with zinc impregnated oxide. It's a bandage. It's soft, so you dip it into water and it's soft. It's like wrapping, just doing a wrap, but it's soft. It's soft and it's a little mushy, and then you wrap it and it will become a semi-rigid dressing. Not hard like a cast, but semi-rigid. Patient can wear this, can walk on it, can use it for about 2 or 3 days and come back, and then you take it off and apply another one. Okay? I used it for 2 or 3 days. You could leave this bandage on for at least 1 or 2 weeks if you see somebody on an outpatient basis. Okay? This is reported to have a compression of 35 to 40 millimeters of mercury. All right, but note that if you have an anti-embolism stocking, it's only about 16 to 18. So we need custom fit garments for somebody who's going to be wearing these stockings for a long time. And you want at least 20 to 30 millimeters for scars, and 30 to 40 are appropriated in edema for somebody who's ambulatory, because the pressure goes up once you stand. Okay, so you have an increase in hydrostatic pressure, you need a greater compression garment to push the fluid back. So 30 to 40 in somebody who's ambulating, okay? 20 to 30 in TED stockings, you're generally using, what's TED stand for?
Thromboembolic deterrent.
Thrombolytic deterrent?
Yeah.
Does the whole thing stand for that?
Thromboembolic deterrent.
Very good. Thromboembolic deterrent. Okay, so those TED stockings are generally, the millimeters of compression are not that great because somebody's non-ambulatory and they're in bed. Okay, once you're ambulatory, you need to have greater compression. All right. Indications. Lymphedema, we've had this already. It's just a repeat. I did this yesterday. Must have had 2 glasses of wine when I did. That's the problem. All right, contraindications. Unhealed fracture, compartment syndrome. Remember we talked about compartment syndromes? Yes? Said compartment syndromes, Volkmann's ischemia or compartment syndrome can be associated with compression of the...
May I have your attention, please? Our college's coronavirus task force needs everyone's full cooperation and adherence to the CDC's COVID-19 guidelines when you are in the building. Everyone must wear a face mask at all times in public areas of the building. Everyone should observe social distancing, which is 6 feet apart. There should be no more than 2 people on an elevator at any one time. Everyone should wash their hands frequently, and if you feel ill, please stay home. Thank you for your cooperation.
So we can have compression of the vessels and the nerves, especially if we have something like a crush injury, and what they have to do is do a fasciotomy to relieve the pressure of the fascia, which then takes all the pressure off the nerves as well as the vessels, and usually associated with some plastic surgery also. So if somebody's got a compartment syndrome. Current peripheral vascular disease, arterial sclerosis, so these are all things that you don't use it for. Edema secondary to CHF, anything that's ischemic, something that's gangrene, dermatitis, because the moisture can increase the growth, DVT, thrombophlebitis, pulmonary embolism, this makes pretty much sense, right? Peripheral arterial disease, right? So how do we know the difference between somebody who has PAD, peripheral arterial disease, and PVD, peripheral venous disease? How do we know? How do we know?
The color, where the ulcer is.
Whether it's wet or dry.
Color, where the ulcer is, signs and symptoms, right?
Hair loss, nails.
ABI, yes? ABI, what's an ABI? Ankle brachial nicks, what else? What's the patient going to say to you? I walk in the mall, so what are we talking about there? Intermittent claudication, absolutely.
If it feels better when the leg is elevated.
Absolutely, does feel better when it's elevated, when it's down. See, you guys know this.
Yes, we do.
Yeah. You do, you know this. So, make sure you know for the test. Okay. And congestive heart failure, you don't want to increase the stress on that failing heart, right? Hypoproteinemia, check the lab values above 2. Should be above 2. Generally around 3. Kind of. Precautions, impaired sensation or mentation. Mentation meaning, does the patient understand what you're saying, right? Impaired sensation. Uncontrolled hypertension. You want to know why this person's hypertensive. Cancer, strokes, CVAs, something more superficial. What about varicosity? Do people have varicose veins? Do gentlemen have varicose veins?
Yes.
Yeah, everybody has a varicose. What's a varicosity? It's a weakness in a vessel, right? A varicosity. So, if somebody's got varicose veins, it's not contraindicated unless it's very severe. All right, because then you cause collapse. So, you just want to err on the side of caution. If you see somebody's leg or somebody's arm with a great deal of varicosities, then you talk to the physician and they ask him if it's okay to do. Okay? But generally, as a rule, if somebody's got little minor varicosities, it's not contraindicated. But it's a precaution. All right. Pressure. Upper extremity 30 to 60, lower extremity 40 to 80. All right? That's the general amount of mercury, millimeters of mercury used. Too much of this pressure can cause cut off a blood supply, so you can cause ischemia. And too little is not going to do anything. Also, when you have a stockinette and you're placing the stockinette on to absorb that sweat before you put that sleeve on, make sure there are no wrinkles in it because those wrinkles are going to be a site of breakdown. Okay? Just like the same thing it is when you wrap someone. I think Professor Maley needs to talk to you. Yeah. About your summer film. Okay. So the clinical applications, you turn it on. I don't think we have to go through it.
He drove me 3 hours this time.
What?
He has a long commuting distance for his current clinical, so I'm saying now he's got to go about 3 hours.
Where do you live?
Randolph?
Randolph. That's Route 10, right?
Yeah. Pretty much. Yeah, it goes right through Milton.
Well, I don't know if it's you, but you might be, somebody's going to be going to Mountainside, I think. I think it might be you. Mountainside Hospital, which is in Mountainside. That's not far.
I don't care about
It's a half hour. Okay. I went through the turning on, turning off, et cetera, et cetera. First thing, when you turn the machine, you want to always make sure that you turn the turn the intensity of the machine down before you turn it off. You turn it off, you unplug the tubes, you decompress the sleeve and you take off the sleeve. Important thing about when you use compression is that you have to do circumferential measurements prior to and after. Why? Because you have to know if it works, right? So we want to see if it works. So you do compression, circumferential measurements. How do you do that?
before and after.
How do you do that?
With
With a tape measure, but how do you do that? What do you do?
Do it to
What's our landmarks?
the belly of the muscle.
You want to find a bone. So if it's the malleolus, you're going to go above or below, or if it's the ASIS above or below. I always choose to pick below because that's the least amount of tissue. You pick below, you mark it. You do 2 inches, or it's more effective in centimeters, so maybe you do 5 centimeters, 10 centimeters, 15 centimeters above or below, right? But you have to mark it so that when you remeasure, you know exactly where you measured. All right, and there's always human error, so sometimes they say measure twice or 3 times and take the average of the measurements. Okay, so you want to see if it works.
You measure that figure 8 pattern for like the ankle.
If
You measure like you like go for the ankle, you go around and then through, right? I've seen a couple PTs like measuring like this figure 8 pattern. I forget what it's for. Never mind.
it's not for this though.
Okay.
Is it for this?
Maybe. I don't
No,
know. It's been in
I don't
passing.
know. You could measure in a figure 8 pattern? I don't
I'll
know.
have to double
Well,
check.
you can measure any way you want.
Mhm.
You can, as long as it's consistent. As long as it's consistent. Okay? So you could alternate applications, gravity assisted lymphatic and venous return, so you want to elevate the lymph, right? You could also use E-stim, motor level stim, to pump out the edema, right? So we have a pressure on, kind of a milking effect, so what do we use? 10 on, 10 off, 5 on, 5 off, we could do that with a machine. Okay? All right, I told you what to do here, typical maintenance, all right, don't worry about it. Okay. That's it.
So don't worry about typical maintenance?
Well, no,
Well, is
I'm not saying don't worry about it. I'm
is that
just
gonna be
saying
on the test? Do we
that's
really not
pretty
have
much
to worry
common
about it?
sense. That's what I'm saying. Typical maintenance, check the appliance for tears or leaks. If a defect is found, repair the defect, clean the appliance. If the machine's washable, turn it inside out. Check the air hoses, this is pretty much common sense. Check the cables, et cetera, et cetera. Make sure that you look at the machine and you know that it's been calibrated, right? So, and some of you have not used it, so you'll use it today. We'll also do cervical and we'll do lumbar traction. And you'll do modalities too. Those of you who need to do modalities. I will give you additional questions, and I would ask you on those questions, probably Wednesday, to figure out how much time you're going to do something, what frequency you use, what pulse width you use, and what are the indications for something that you're doing to try to get you ready for Monday. Okay? So you okay?
Yes.
And then we'll start gate.
Cool.
I think you'll like gate more.
Oh, yeah. Without a doubt.
Alright. So that's it, we have time, which is good, so we'll take our time and walk over. And hopefully we can maybe start a little bit early. We never have enough